Thank you, Kevin. It's great to be up here. Actually, I'm not going to tell you what I haven't learned about how government works. That'd be too hard. So what I'm going to do is I'm going to spend a few minutes just telling you about the Agency for Healthcare Research and Quality. It's an agency I've just been with a short period of time. And as Kevin mentioned, I sort of made the tour of different jobs. What's different about AHRQ is that very few people know what it is. And so it is valuable just to mention who we are. When I was at NIH, everybody knows what NIH is. Everybody knows what UCLA is. But actually, remarkably, very few people have much idea of what the Agency for Healthcare Research and Quality is. So let me begin by saying that we have a new director who's been there about a year, and I actually had worked with him when I was at UCSD. So, and we have a new mission, and the mission is to produce evidence to make healthcare safer, higher quality, accessible, equitable, affordable, and to work with these other agencies and other partners just to make sure that evidence is used. And this is actually a very important goal. It's all healthcare oriented, and as we get into the behavioral economics discussion, I just want to emphasize that, why do we care about healthcare? Well, American healthcare is the biggest sector and the biggest economy in the history of the entire world. So I think it is important that we attend to what we're doing. So we have these different priorities. One is to produce evidence to make healthcare higher quality. Second, to produce evidence to make healthcare safer. Third is to produce evidence to increase access to healthcare. And then the fourth one is fairly broad. It's to improve healthcare affordability, efficiency, and to improve cost transparency. We are, as agencies go, a pretty small agency. I'll tell you about the budget in just a minute, but we do some activities that some of you may be familiar with. So, for example, we run the evidence-based practice centers, which do the evidence-based reviews that form the basis for a lot of evidence-based guidelines. We provide the staffing for the United States Preventive Services Task Force, AHRQ, who we'll hear from tomorrow, as former chair of that. By the way, I think it's worth saying, having watched the task force work, very evidence-based activity that starts with these evidence-based reviews, and then it sets policy. So making recommendations for what services should be offered in primary care. And those, if that service is now ranked as an A or a B, it will get covered under health insurance plans with no copayment. So that it's a small activity, but in fact it affects just about every primary care practice in the country, and through the primary care practices affects essentially the entire population. So again, coming from NIH with a very big budget, we have a very small budget for a federal agency, about $460 million, and about $170 million of that is in grant activity. We use more of our money to create databases and do other activities and running centers and so forth, like centers to improve hospital safety. Now, I just wanted to mention that we're not doing some of what we used to do, and so this is an area of some confusion for our agency. So we used to do a lot of studies like this one. This is a study that was published in the New England Journal recently that looked at people with spinal stenosis who got injections of corticosteroids plus lidocaine or just lidocaine by itself. And in terms of patient-centered outcomes over the course of 6 weeks, it didn't make much difference. And in fact, AHRQ was doing a lot of studies in this area called comparative effectiveness, but now we've handed that over to the Patient-Centered Outcomes Research Institute. You'll hear a little bit about tomorrow. So we actually are giving up our mission of comparative effectiveness research, and instead we're focusing on the dissemination of patient-centered outcomes research. And there's a lot of this, and so again, we get to the behavioral economics component of this soon, but we're very interested in these problems of evidence-based practices, how many of those actually get delivered to people. And it's been suggested that patients only get about 50% of the evidence-based or the practices that are supported by evidence. It actually has gone up a little bit. Our most recent report shows that actually in the recent years, more patients are getting these services. But in fact, there are many services. For example, these behavioral health services for addiction and so forth actually are not used very often. So I wanted to take a couple minutes just to talk about economic issues, and I want to just kind of give you a personal history. As Kevin mentioned, I spent many years at the University of California in San Diego, and then I moved to Los Angeles. And when we moved from San Diego to LA, we lived just north of San Diego in the university. It was 90 miles from one house to the other. You could make it in like an hour and a half if you did it in the middle of the night. 8 o'clock in the morning would be about 3 or 4 hours. But in terms of other things like healthcare, it's like moving to Mars if you go from San Diego to Los Angeles. Things are remarkably different. Here's San Diego on a typical day in Los Angeles. So I saw Jason Doctor kind of sneering that. Well, one of the things that I had been doing, I spent some time at Dartmouth along the way and had looked at the Dartmouth Atlas of Healthcare and realized that, in fact, there's remarkable variation. And one of the areas where there's remarkable variation is San Diego versus Los Angeles. So if you just look at what the Medicare program spends in hospital service areas in Los Angeles County versus San Diego County, it's remarkable. So the least expensive hospital service area per capita expenditures in San Diego and Los Angeles County is Torrance, down by the LA airport. And then the most expensive hospital service area in San Diego County is a community called La Mesa. There's no overlap. Actually, there's actually no overlap at all in these distributions of expenditure, or the mean expenditure. And so we got very curious about why this is so. I just wanted to make the point that these aren't trivial differences. So for example, if you take the LA County costs minus the San Diego costs, times the current life expectancy when the average person enters Medicare at age 65, it's a differential of about 3,000 some odd per year, and then multiplied by the 18.6 years of expected life expectancy. Well, what happens is you could buy one of these, actually, for every single Medicare recipient in Los Angeles County if they're just willing to accept the health care that people got in San Diego County. By the way, there's 1.3 million Medicare recipients in Los Angeles County, so this is serious money. So what are we doing about some of these issues at AHRQ, and what are some of the things that I just wanted to tee up for general discussion? Well, we are engaged with a variety of activities using a fund called the P-Core Trust Fund. So we have two sources of revenue at AHRQ. One is appropriated dollars, and the other is money that comes from the Patient-Centered Outcomes Research Trust Fund. That, again, you'll hear about P-Core tomorrow, but about 80% of this trust fund, which was created by the Affordable Care Act, goes to the Patient-Centered Outcomes Research Institute. About 16% comes to us, and 4% goes to the Office of the Secretary. So one of the things that we've become very interested in is how can we use research like that comes from behavioral economics to accelerate the rate at which findings get used in practice. So we know, for example, that it takes about 17 years to turn about 14% of findings from original research into activities that could potentially improve outcomes for patients. One of my favorite examples, and one that we're pursuing some, has to do with the management of blood pressure. So if you look at a lot of areas of medicine, probably one of the most persuasive areas is management of cardiovascular risk factors. And there's probably less debate about the value of managing cardiovascular risk factors than a lot of other things in medicine. One of my favorite examples, since I spent years at the NIH, was that FDR had dedicated the Building 1 at NIH in 1940. And at the time, actually, and through his history, his blood pressure was very poorly managed. So if you look at the readings leading up to his death in 1945, in March 44, his blood pressure was measured as 186/108. And then if you just look at these successive readings, actually in February of 1945, it was actually measured as 260/150. And in those days, interestingly, they would sedate him. Occasionally they would put him in the hospital, but there really wasn't a management protocol for high blood pressure. Where since the Framingham Heart Study over 60 years ago, we actually have known what the risk factors for coronary disease are. So we know that managing tobacco smoking, managing blood pressure, cholesterol, and diabetes are the major risk factors for death from coronary disease. But in fact, we're still doing relatively poorly at this. And so, for example, if you look at the proportion of the population that's aware they have high blood pressure, it's about 8 in 10. And among those, about 70% get treated, and among those, only about 50% are controlled, even though there's a lot of evidence that you can control blood pressure in almost anyone, although it may take 3 drugs to get there. this actually can be achieved in most people. So one of the things that we're doing at AHRQ is we're looking at ways that we might be able to accelerate the dissemination of this information. We know it can be done well, so we have examples like Kaiser Permanente, for example, that does a remarkably good job of managing blood pressure and other cardiovascular risk factors. Where in small practices, we know that we do a remarkably poor job. And so are initiating a series of grants. We're going to spend about $50 million on this over the next year. And some of those grants will be awarded relatively soon. Another area that we've become very interested in is how can you change incentive structures within organizations to improve delivery of care, looking at the organization as the unit of analysis. And so we're going to spend about $10 million on this effort in the relatively near future. We actually are about to review those grants. So I know I'm just about out of time, so I want to just mention two other things two other sort of issues that we become intrigued by. And because I'm not really a behavioral economist, it'd be good to get your feedback on them. So one is what we call the apple pickers and federal judges problem. And it goes something like this, that we have different payment systems for people who do different types of work. So the apple picker, for example, gets paid by the apple picked. And in fact, you can do this in different ways. So you can actually pay them by the good apple. So if the apple's bruised or if it's the wrong size, just don't pay them. And this produces a ton of apples, a system that works very well. And then we have federal judges. And federal judges we pay on a salary. And in fact, you might argue that you don't want to pay federal judges like you pay apple pickers. And the reason for that is that would be perverse incentives. So for example, you wouldn't want to pay a federal judge based on the number of convictions. So the question is, well, how should we pay healthcare providers? Well, there are consequences of these different payment systems. So for example, it's been argued that a fee-for-service system might provide, and this is what we have in a lot of aspects of medicine. So fee-for-service providers may do too much and do activities that don't help patients. A salary system, providers would do as little as possible for as few people as possible, might be argued. Global payments or capitation, providers might do as little as possible for as many people as possible because they're getting a bulk payment. And then there's pay performance, which has actually been the rage for the last few years, but we're learning now that there are all sorts of unexpected consequences. And I think I better wrap up in a minute, so I won't go into the details, except for to say that there are an emerging number of studies in the literature that show that when you play with these payment systems, you do all kinds of things that are unexpected. So this is the case of Mr. Smith versus Mrs. Jones. They're both age 50, but they start with different baseline blood pressures. And in this case, you pay the provider when the person's blood pressure comes under control to find a systolic blood pressure is lower than 140 or diastolics lower than 90. So in this case with Mr. Smith, they got his blood pressure from 190 down to 150, and they actually halved his risk of a stroke. Where Mrs. Jones went from 141 to 139. Mr. Smith's doctor got paid, where Mrs. Jones's doctor did not. I'm going to just sort of wrap this up. I just want to conclude with one of the most intriguing findings or discussion items, just to tee this up because we're almost at the cocktail hour. The question is, are there generalized cross-species principles of behavior? And this is a comparison between rats. By the way, are there any ophthalmologists here? Ah, good. And ophthalmologists. So, and here's the finding, that some of my friends who work in animal labs and study behaviors in using experimental analysis of behavior tell me that if you look at the rat literature, you can do things, and token economies are actually regular sort of reward, where you can develop different response patterns. But one of the things that happens is if you have food-deprived rats, and they can earn a token for a specific response. Okay, so they learn to press a bar for this token. Well, what happens if you cut the rate in half? By the way, would you say that they would increase or decrease their responses? Actually, they double the volume, so that it's so if they're hungry, but not if they're not. If they're hungry, they'll actually double the rate of responding. But But if you give them an alternative activity, so instead of pushing the bar, they can do some other behavior, then they'll have the rate of responding. Well, it turns out that if you look at cataract surgeries, that cataract surgeries at one point, Medicare, by the way, cataract surgeries are important because cataract surgeries were the most expensive item in Medicare in the 1990s. And so it's an enormous amount of money. What happened was that the Medicare cut the rate of payment for cataract surgeries, and ophthalmologists said, well, we just won't do them anymore. Well, it turns out that, in fact, those who made their living primarily doing cataract surgeries actually doubled their output. And in fact, there are other payment changes. For example, when some plans switched from fee-for-service to contract capitation, in fact, rates went way down. So in fact, ophthalmologists and RATs responded in a very similar way, suggesting that there are generalized principles of behavior. So how do I conclude all this? Well, first of all, AHRQ is a federal agency. A lot of people don't know about us, but we do really interesting things. And in fact, it's a group of physicians and behavioral and social scientists. But everyone in AHRQ actually is interested in these areas. So look for opportunities with us. You probably will see some over the next few years. And thanks for having me.
So I'm here to talk about the White House Social and Behavioral Sciences team, which I guess I should make a correction, which is that it's not the Behavioral Insights team. It really is the Social and Behavioral Sciences team, or the SBST. But don't worry, Kevin, you're in very good, comfortable company. That gets confused all the time. SBST, I guess, is a little bit of a mouthful. But it does reflect the breadth of the field and the fact that we really do envision ourselves as being sort of a conduit into the federal government for the entirety of the social and behavioral sciences. And the sort of core idea with the group is to actually take academic researchers and researchers from other sort of settings, bring them into the federal government as sort of a small team that's available to agencies to sort of work very closely with agencies to learn about the mission that they're undertaking, the sort of things they're trying to accomplish with their programs, the sort of practical constraints that they're working within, and to sort of think within that context about how insights from the social and behavioral sciences are going to be relevant to the programs. And sort of think through what are the things you might do differently that can improve on those programs, make them a little bit more sensitive to what we know about social and human behavior. And as sort of an integral part of that, since we're not really comfortable just making wholesale suggestions always, we don't always know exactly what's going to work best, is that an integral part of the team's work is actually doing field experiments. And so we'll work with the agency to try to embed trials to sort of be able to test ideas, to learn what's working, the sort of relative effect size, and sort of think through how that has implications for doing policy A versus policy B, for instance. This is where I think it becomes important that the team is actually, even though it's drawn from academia, so for instance, I'm hailing from the University of Arizona. One of my colleagues, Bill Congdon, is in the audience. He was at IDS 42, Brookings Institute before that. You know, we're really coming into the government, though, and wearing a federal employee hat and getting in the trenches with government officials. And I think this is critical for sort of developing that relationship, understanding those kind of dynamics I was talking about a minute ago. What is it that they're actually trying to accomplish? What are their priorities? What are the sort of practical constraints that they're working in? And it also comes with certain, privileges and responsibilities as a federal employee. So sometimes you can actually get access to databases, for instance, a little bit easier than you could if you were on the outside. And so it becomes a really sort of an interesting dynamic to try to catalyze the sort of work that I think so many of us are doing within the federal government. And just to tell you a little bit about the team, you kind of pull back the hood and peer into it, there's about 10 of us right now, coming from different sort of fields. Myself, like Kevin was saying, have a psychology background. Bill is an economist. We have others on the team that have backgrounds in social psychology, economics, public policy, law, medicine, sort of a diverse mixture of things, but all of which come with sort of experience doing work within this applied behavioral science umbrella term. And the institutional structure of our team is pretty flexible and evolving. And so we have leadership coming out of the Executive Office of the President. The actual team itself was put together by the Office of Science and Technology Policy. And we have people that are both there in the EOP, and then we have a core group of persons that are actually positioned at the General Service Administration, which, if you haven't worked in government, maybe sounds a little random. I didn't actually even know what the GSA was whenever I started. But it's actually an agency that's set up to be able to assist other federal agencies. And so to the extent our work involves working across the entirety of the federal government, various agencies, HHS, Department of Labor, Education, whatever the case may be in position, sort of structurally having a backbone at GSA empowers us to do that cross-agency work in a really exciting sort of way, especially whenever you couple it with that leadership from the White House directly. And so that's a lot of the flexibility there. We also have lots of partners that are actually at agencies, of course, the ones that we're working with on any particular project. Let me tell you a little bit about sort of our startup strategy, because I should have mentioned that we're new, quite new. The team itself sort of came together January of this year. And we've been in this sort of startup mode of trying to kind of find our footing within the federal government, figuring out the best ways to do this work, and also trying to get projects done early on, both as sort of proof of concepts that this sort of thing could work. And so I think if you look at the portfolio we currently have, the projects tend to have some common features. So we tend to try to find those instances where the federal government sort of owns the delivery chain, so to speak. You know, they're doing something that directly touches on the lives of citizens, so that there's something there that we could actually look at and change and randomize within, so that you can sort of embed a randomized controlled trial or experiment sort of directly in something the federal government is doing. Turns out that lots of things the federal government is doing actually involves, you know, handing out money for something that other people will do. So we're trying to find things they're doing directly. And then trying to find things that the outcomes that we care about are already being captured by existing administrative data, which here is sort of taking advantage of a data set that's already been collected. And when you put those two things together, you can start to do really important experimentation at very low marginal cost. You know, maybe the cost of that original putting in place of the delivery chain, the original cost of putting in place the administrative data set was very, very expensive. But what we're talking about is sort of coming in at the tail end of that and iterating within those existing parameters. And so here's two examples within the healthcare sphere. I'll take a sip of water and have a dramatic pause. That have both of those dynamics, and they're both letter experiments. And whenever I say what the actual interventions are, it's going to be very familiar to people in this room. Some of you probably invented or tested them at certain points. But one project was with the Center for Program Integrity, which is a sub-office of CMS. They sort of monitor for fraud, waste, and abuse within Medicare. This is a project that was done also with input from Adam Sakarni and Amy Finkelstein. So sort of illustrates this dynamic. We oftentimes reach back to academic colleagues to put together these projects. And what CPI, or Center for Program Integrity, was interested in doing is they had been sort of culling through the claims data and identifying what looked like unusual spending patterns or claims data for providers. So these were doctors, for instance, that were prescribing way more of a particular drug than their peers, way more substance to control drugs, for instance. And they were going to be sending out informational mailers to them, sort of informing them about that, and sort of providing some resources for things they might go back and look at to sort of reassess their practice and ask this question about whether they may be prescribing too much. And so what we did is we worked very closely with CPI to first say, you know, if you're going to be doing something like this, why don't we actually first stop and test whatever it is you're going to be planning on doing. So if you want to send out a letter, why don't we actually just stop and take the population you're going to be sending it to, and instead of just sending out one letter to everyone that was sort of your best intuition, let's instead randomize and send that letter to half the group and not to the other half. And then we can look at claims data again to see if it actually worked the way you thought it did. And so once they were sort of on board with this idea, we also sort of introduced some behavioral dynamics into the letter itself, trying to simplify it, make the opening page a little bit more friendly, and then also introducing a sort of social comparison dynamic, the one that's often used, I guess, with utility companies, where if you point out the electricity usage of your peers in the neighborhood, and you're someone who's been an outlier, which you'll see in the next billing cycles, it tends to go down. So we introduced a dynamic like that into the letter. Those letters have gone out now, and then we'll be able to look again at the claims data at the end of the day to see what sort of differential effects emerge. One other example that has a similar letter flavor feel here is one that was done with the National Vaccine Program Office at CMS again, that was interested in increasing influenza vaccinations. And this was letters that was going out to Medicare beneficiaries, where again we had conditions where there's just no letter at all, or a letter, or multiple variants of the letter. And what we did there is we had one version, which was simply an informational letter, talking about the availability of the vaccine, the fact it was covered, and so on. And then for other versions, what we did is sort of at the bottom of it is introduce this kind of PS tag, where we did some things like including an implementation intention, which this is just a fancy word for like a blank space, where you write out how you plan to implement your intention. So in this case, it says something like, hey, when do you actually plan to get your vaccine? Some people find it helpful to just write that down and stick it on the refrigerator. And then there was a blank space where they could write down the day and time that they were going to do this. And so here again, those letters have randomly sent out. We'll be able to look at Medicare claims data probably in January or so to see if it actually impacted the uptake of this. This is work that's had input from Natish Chowdhury and Sarah Tom. Those are a couple examples. I think the last little comment I'll say is sort of, we're very interested in continued researcher engagement. And this can take several different forms. Most obviously is that we need people on the team. So I think the dynamic that's going to be healthiest here is sort of having a rotating fellowship program where we have people coming in from academia, spending some time with the team, getting to know sort of the opportunities with the federal government, seeing how that works, and really kind of getting into the trenches to be able to embed this kind of experimentation directly. And so if you think you might be interested in a fellowship, or if you have a grad student that might be interested in an associate sort of position, there are those kind of opportunities that will be coming down with the pipeline. We'll probably have another solicitation come out in the spring, maybe in January. Sort of short of that is opportunities for kind of ad hoc project collaboration. And so in the two examples I gave you, I was mentioning some names of folks that have been working with the team on an ad hoc kind of basis, providing various types of support. It could be ideas, it could be some of the person power in terms of driving development of stimuli, doing analyses. There's kind of a lot of different options you can start to think about how it might be mutually beneficial to work together. And then the last sort of two categories is that one idea we're starting to play around with is a sort of visiting scholar program where, we're sort of playing around with the best way to do this, but having in mind something like having people fly into DC for a couple of days, maybe give a talk to a general audience, maybe have a few meetings with agencies, maybe spend some time with the team, sort of sharing ideas, and then you go back home. And then the final category is just being colleagues. If you have great ideas or questions or suggestions for any things that we're doing, feeling very welcome to send us an email, pick up the phone and call, and just like you would collaborate with anybody else in the field looking at this in the same way. And our emails all tend to be pretty easy. For me, it's david.yokum, Y-O-K-U-M, at gsa.gov.